Good afternoon. I'm KathleenSharp, and I'm with Geisinger Health System. For those of you who aren't familiar with Pennsylvania, most people know Pennsylvania as Pittsburgh, Philadelphia, and everywhere in between. Geisinger is in the everywhere in between. We're in 45 counties in Pennsylvania. We're the country's largest rural healthcare system. I am an innovation resource within Geisinger, so I'm an internal consultant. I'm one of those Lean Six Sigma geeks. But I worked very closely with Dr. David Schoenwetter as we built this innovation and built the program at Geisinger. So I'm really happy to tell the story of how we got to where we're at and where we're going to. And we might have another first for you. Okay, so our goal in creating the mobile health paramedic program was part of our community-based care initiative. We were looking at what are other mechanisms that we can use to get out into the community. So there are problems in rural healthcare that you have to solve. They're nice to solve if you're in an urban setting, but you really have to solve them if you're in rural healthcare. So one of the things that we looked at is how do we bring services out to the members of the community, and it ties in with the triple aim. We certainly want to look at how do we provide the right care in the right timing. This is a very nimble, flexible clinical resource that we can deploy very rapidly. So that was the vision. Now we have count them three mobile health paramedics. That's what we have for the system. We're operating out of one of our hospitals in Wyoming Valley, which is near Scranton. So those of you who were fans of the TV show The Office, it's that community. And what we found is that in recruiting that resource, we needed to be looking for a different type of paramedic. So the paramedic that was really charged by lights and sirens and the adrenaline rush, if they didn't have good social skills, if they didn't want to spend a lot of time building rapport with patients, this isn't for them. So it's not a one-size-fits-all. Not every paramedic is well suited for that and would enjoy this type of work. We also needed to look at what other programs did we already have in place, because we have a very robust care management system. Care management works, but there's some gaps in it. We have a really good home health service, but there are gaps in that. So how do we use this to provide integration without duplication and without competition within those resources? So we really focused on three things. We looked at the utilizers in the ED, those frequent flyers that were coming in and out, those patients who had medically complex conditions, and heart failure patients. So here's some of the attributes. As you would expect in a telehealth conference, we had a need to make sure that we had the right type of technology available to our patients and to our care providers, not only for the paramedics themselves, but who was on the other end. So the people on the other end could be an ED physician, it could be a primary care physician, or it could be a cardiologist. So we've expanded into all three of those arenas with technology. We needed to make sure, again, that they were really establishing a very strong rapport with the care managers and with the nurse navigators who help support our proven care heart failure initiatives. That was really important and something that we really needed to check, and we built it into our training and constantly reinforced this, that the paramedics' role was to strengthen the bond between the patient and their care providers, not to interfere with that, not to be the hero in the middle, but to be the person that facilitated that growing marriage between the patient and their care team. It was really important, again, that we look at the different gaps in care, which meant we needed to know what those are. Now, Geisinger has been on Epic. We've been on an EMR for over 20 years. So data, we've got it. We've got lots of it. So this gave us an advantage to be able to look and see where are the gaps? Do we know where the gaps are in the communities that we serve? How do we anticipate that for patients before we go out there so that we're really making sure that we're crossing those off the list? The other thing that we found is that not only within the community, but within our own organization, we needed to explain what a paramedic could and couldn't do. In much of our community, and certainly even inside of Geisinger, there was a fear that we were asking the paramedics to do more than what they were actually allowed to do. Instead, we had to help them understand that we weren't expanding the scope, but we were fully utilizing the full range of what a paramedic was allowed to do and really leveraging that. Not only was that great for providing the right type of care, but think about what that means for that paramedic that is in their mid-40s or older. Knees and hips are getting tired of running upstairs with litters. And so carrying patients in those scenarios, what happens to them now is we lose them. We lose all of that knowledge in this type of role. So a mobile health paramedic program is ideal because you're able to capitalize and leverage that skill set that has been finely developed over, in many cases, decades. So this is a range of the different types of service that our program offers. Everything from connecting with care managers on medical home support, advanced medical home. We also coordinate very tightly with our heart failure nurse navigators. Those of you who follow Geisinger know that we have proven care, which in lean parlance means that we have standard work for providers to follow for particular types of disease. It's our checklist for how we're going after heart failure. And so we found that the paramedics, there were a number of the proven care protocols that they could be initiating when it came to follow-ups for phone calls on a prescribed basis. And we've had some really striking results, and I'll share just a couple of those toward the end of this. We also found Discharge Plus, which is the name that we created for the program. For those patients that present to the emergency department, our ED docs often refer to them as tweeners. They're the patient that comes in, they don't meet admission criteria, they aren't quite sick enough to be in observation, but they're crossing their fingers when they send them home. Now they can also have a paramedic following up with them on a prescribed regimen for 2 to 3 days after that, making sure that that patient is well attended to, that we have a good idea and a solid understanding and connection with what other services they might need to make sure that they're safe and that it's okay. We also have used them to help close the gap in advanced directives. And in Pennsylvania, the Pulse form, all of our paramedics have had that training, and they're very good about holding that very difficult conversation in a setting where sometimes on the inpatient setting, the patients say, talk to the hand, I don't want to talk about that, I'm nervous enough about being on the inpatient setting, and now you want to talk to me about end-of-life decisions. It's very different when we're able to do that at the kitchen table. So it's also fostered that relationship with their care team. So here's some of the things that we have available in our program. Yes, Allegheny ahead of us by 31 days. But we were able to document in the field real time in Epic, receiving orders from the ED provider, and again, a paramedic needs to be receiving those orders from a provider that's designated to provide medical command. So they can't take their orders from just anyone. It needs to be an ED provider with medical command. But I'll show you on the next slide one notable exception. We're also able to transmit, again, not brand new technology, but we were able to leverage that to be able to transmit 12-lead EKGs. So if you happen to be the ED provider that is monitoring those patients, you're on call with the paramedics for that. That can be sent directly to your phone, or any other device. So it's a really great way of leveraging long-standing existing technology and tying all three of those pieces together to get a good 360 view of what's going on with that patient. The cardiologists absolutely love that. So there's the plan and then what happens. Here was our plan. We thought we had this nice, tight design and how we thought the paramedics were going to be spending their time. So about just a quarter of their time with heart failure patients, medical home, our ED patients coming out from for Discharge Plus, and then hospitalization at home, which was one of the original designs that we had. But this is what the reality is. Overwhelmingly, the vast majority of their time is spent with heart failure patients. So our pilot results, anytime a patient goes out, a paramedic goes out to the home, they record and log all of that information. We have validation then through Epic, so we have 2 ways of cross-validating the information, and they will indicate whether or not they think that visit would have otherwise been an ED visit or an admission or some other type of service was needed. That is then reviewed by our quality department and our medical director to confirm. And again, that's self-reported, and then we validate that behind the scenes. So these were the outcomes that we saw just in the pilot. And so our CFO was a little disappointed, honestly, because he said, that's 42 hospitalizations I would have been paid for. You guys are doing a great job, but you're killing me on the revenue side, because we would have been paid for all of that. So understand that that's one of the risks as you start to think about embarking on this. We survey 100% of the visits. 100%. Our response rate is phenomenal. Right now for April, we're running at 100% response rate. Now the 5 stars, that's not our average score, that's our only score. We've only gotten 5-star reviews, and the comments have been really heartwarming in the patients that we've gotten those replies back from. We share that with our paramedics on a weekly basis, and the responses come back within usually 4 days of the time that we send them out. I send them out personally. We designed the survey, and when you're this close to the program, you worry about survey bias. So we had it reviewed by research. They said we don't see any bias. It was getting 5 stars for 3 months in a row, and that still made me uneasy as a data geek. So we sent it over to PreSummitSessionA. They said there's no bias in the survey. Here we are 2 years later. We've never received anything but a 5. So we've just asked PreSummitSessionA to review that again. Their response replied and came back to me on an envelope which landed on my desk on Friday. I was afraid to open it before I came to the conference, but I did. They said there's no bias in the survey, so really important. But we also want to look at 360 satisfaction. So you'll see on one side, these are some of the comments from the patient. It gives you the typical flavor of what we hear. But we also talk with the care managers, the PCPs, the cardiologists, and other members of the care team to say, what's your experience? Is your patient more connected with you? Are you feeling that they are more compliant? We have other data that we can look at their clinical outcomes, but what's the relationship? And they said it's just tremendous. So we started out in cardiology with only 1 physician champion. Now, if you were to talk with our cardiology team, all of the cardiologists in the site that we're operating out of use this and said this program just has to continue going, and we'd like to see how we can expand it. So great support. So here's just a taste of some of the results that we get. So we showed you on an earlier slide what the paramedics were self-reporting and then were validating behind the scenes. When we did a deeper dive just into the heart failure patients, and the other patients had very similar results, this was a 90-day pre-post of 202 heart failure patients. And you can see we dramatically reduced the number of encounters that patient had with the inpatient side of our facility or the ED side. So anytime they touch the facility, that's that first set of bars. Only a slight reduction in ED-only visits, but big reductions that we saw in overall admissions. And our readmission rate for these patients fell by 24%. So CFO was starting to brighten up a little bit when we told him that. But when we looked at those patients, those heart failure patients that were admitted, you can see we started out with 282 admissions for that particular population. Afterwards, we cut that to 133 admissions, and you see the length of stay, the average length of stay for those patients went up, which meant we were targeting the right people. We were getting the sick people who really needed to be in. And this is our chief medical officer's favorite slide, because when you look at the length of stay in hours, we ended up saving 599 bed days. That's the equivalent of building 5 beds, a 5-bed unit on our inpatient chassis. So our chief medical officer said, you know, you had me at capacity, because we are struggling with having such high volumes. We're running well over 93% census ratios every day. So to be able to have that capacity and not have to be thinking about bricks and mortar, another way of providing care, this is a great way of doing that. We've gotten some notoriety and some recognition. So this program was featured in the Wall Street Journal last August. It's also won 2 national awards that we're very proud of our team for the work that they've done. It was designated as the Innovation of the Year. We just accepted that a few months ago at ACEP. And as one of the integrated healthcare systems to watch, this was the program that helped us cross the finish line there. It's also been featured a lot on the local news, and we've gotten a lot of media attention. We're trying to, you know, say, let us continue to focus on doing the work. But what's been very interesting is when we get these different outlets that call us, they say, we want to talk to a patient. When you have only 5-star reviews, we're just picking numbers out of a hat to say this might be a good story that you might be interested in, because we're not concerned at all about how that might be reflected, and the patients have compelling stories. One interesting challenge that we've run into, though, is patients are hard to get in touch with because now they are feeling so much better, especially those patients who've had home diuresis, who were homebound. We had one lady that was homebound for 3 years, couldn't go grocery shopping, and when we thought, this is a great story. She's been cared for by her family, and now she doesn't need that support. We couldn't get in touch with her for one of these media stories because she was in New York not being cared for by her family, but to care for her twin grandbabies. So she's out in the community living life. We had another gentleman that was homebound for a year, and he just won his country club's golf tournament. So, I mean, we're hearing some dramatic turnarounds. And again, it's the connection. It's not the paramedics by themselves. It's their connection and their integration with the system to allow that care team to really partner with the patient to get their health turned around. So here's some rough volumes for you. So we, as of the end of March, we're just shy of 1,000 patients enrolled. And you can see around 3,600 total touches with the patient. So some of these patients are only phone calls. Some of these patients are a combination of visits and phone calls. Our heart failure patients, roughly 2/3 of them also had home diuresis. And for those of you who aren't clinical like me, if you see me with the Band-Aid, I'm probably going to need help. But the home diuresis is when they're giving them Lasix, they're overloaded with fluid. And so the paramedics are able to provide that service at home. Now, they don't do that service under an ED physician. We have a delegated practice model where they're actually operating under the license of a cardiologist who's monitoring them. So again, we've expanded the connection and which doctor they're seeing on the other end. So this is our team. And again, we have 3 paramedics that are at the very front of the vehicle. Dr. Schoenwetter is in the suit toward the back. And then myself and 2 other folks that have helped us to design the program and continue to monitor that. We do daily metrics. We do daily huddles. We do a lot of the basic tenets without using a lot of lean geek speak. We use a lot of those same principles to make sure that we can monitor and iterate daily, case by case, to improve the service. And being the data geek, I just had to show you an example of, these are the type of metrics that we look at. So process metrics, and then the right process metrics are going to help guide and help you move your outcome metrics. The CFO still not a huge fan of the program, honestly. He can't deny the quality. We haven't, but when you're going into budget cycles and people are looking at, gee, is this drive revenue? No, it doesn't drive revenue, it only drives cost. Does it? But it also prevents revenue. For us to be able to have this data readily available to us, that has saved us multiple times by being able to demonstrate the actual value of the program to the community. Geisinger, if you've been following us at all, you know that we are celebrating our 100th year this year, and we welcomed a new CEO who is a very, very strong advocate of the program, and of course that has paid many dividends for the program as far as getting us out and having the community respond to us. So that's just a taste of what we're doing at Geisinger, and I'll turn that over to Jack.